Welcome back. For this lecture, we're going to discuss the basic physiology of ventilation. If you recall, when we discussed the anatomy and physiology of the airway, we described three key terms that we would need to further define and be familiar with: ventilation, respiration, and oxygenation. For this lecture, we're going to talk about ventilation. This lecture is intended for EMT basic students and as a refresher for EMTs and paramedics. There are partner lectures in the series that go further into depth regarding the subject. Remember that ventilation is the physical act of moving air into and out of the lungs. There are two processes in which we evaluate during ventilation: inhalation, or the active process of moving air into the lungs, and exhalation, the passive process of air leaving the lungs. During inhalation, the diaphragm and intercostal muscles contract, and this generates negative pressure in the thorax, allowing air to enter. The process is known as negative pressure ventilation. During inhalation, the lungs require the movement of the chest and the supporting structures to expand. The exchange of gases is driven by a concept known as partial pressure. The partial pressure of gas drives oxygen and carbon dioxide to and from the lungs and to and from the capillaries outside of the lungs. Oxygen and carbon dioxide both diffuse until the partial pressures in the air that is inside the lungs and in the blood are equal. During inhalation, the diaphragm will contract. Remember that inhalation is the active process. Inhalation causes the diaphragm to contract and move downward away from the thoracic cavity towards the abdominal cavity, thus expanding the volume of space within the thoracic cavity. This expansion of volume reduces the pressure and forces air to enter into the lungs. During exhalation, the diaphragm and intercostal muscles, or the muscles between the ribs, relax and restore to their normal shape. This causes a shrinkage of the volume of space within the thoracic cavity, increasing the pressure in the thoracic cavity, causing air to leave the lungs. Inspiration delivers oxygen to the alveoli. We can measure the volume of air moving in and out of the lungs, and this term is noted as tidal volume. Tidal volume for the average adult is about half a liter or 500 milliliters. We do need to understand that not all air leaves the lungs during the normal inspiration and exhalation phases. There is air left in the lungs that we note as dead space, and this is the amount of air that remains in the lungs after normal exhalation. Forced exhalation can remove some of that air from the dead space, but in general inspiration and expiration process, that air remains and is mixed with incoming air as it comes into the lungs. Exhalation does not normally require muscular effort. It is indeed a passive process. As described earlier, the diaphragm and intercostal muscles relax. This creates a smaller volume of space in the thorax, which compresses the air, thus causing the air to leave the thoracic cavity and exit the body. Regulation of ventilation involves a complex series of receptors and feedback loops. In the normal, healthy patient, this process is governed by the pH of the blood and cerebral spinal fluid. During normal ventilation, the pH is maintained, and if that pH changes, the body will then send a signal to the brain, and the brain will adjust the respiratory rate and tidal volume to compensate appropriately. This is known as a carboxic drive. In patients with end-stage COPD, they may have what's known as a hypoxic drive as opposed to a carboxic drive. The hypoxic drive is when respiratory rate and volume is driven by the concentration of oxygen as opposed to carbon dioxide.